ALL was the first indication for approval of CAR T-cells in children and young adults up to the age of 25. And I would say that this is also the disease in which we have the best success of CAR T-cells. So I will discuss the big studies, both from Europe, from the States, and from China, of CAR T-cells in adult ALL, about the efficacy, about the prognostic factor. So we know today, after a few years of therapy, that there are several prognostic factors for success of CAR T-cell in adult ALL, including platelet count before giving the CAR T-cells, LDH, which is a factor of the disease, and new data are coming about mutation on p53. It is also predicting a response to CAR T-cells, and if the patient had in the past allogeneic stem cell transplantation. And I'll devote quite a big part of my talk to whether we need to do allogeneic transplantation post-CAR T-cells, because this is crucial. Is the CAR T-cell a final therapy for ALL, or this is just a pathway for allogeneic transplantation, bringing the patient to transplant in a better condition? So there is controversies about this. Studies that show that allogeneic transplant is not improving the response to CAR T-cells. Others show improved response, but there are more and more data, including a paper that was published this year about more than 430 allogeneic transplant, CAR T-cells, in ALL, showing this is pulling of many studies, showing that the relapse rate in patients that received the allogeneic transplant after CAR T-cells are significantly lower than the relapse rate in patients that received CAR T-cells, have achieved CR or even minimal residual disease negativity and did not receive transplant. So the recommendations are that in patients that lose the CAR T-cells fast or didn't have a previous allogeneic transplant, we should offer them CAR T-cells. And then a bit about the toxicity, starting earlier with tocilizumab and even giving a low dose of steroids, and new approaches for CAR T-cells in ALL, including CAR T-cells again, CD22, sequential administration of CAR CD19 and CD22, bispecific CAR for CD19 and CD22, allogeneic CAR, and other new approaches for the challenges that we still have in CAR T-cells, and those are mainly the CD19 negative relapse. This is up to 40% of the relapses after CAR T-cells, and for the persistence of CAR T-cells and toxicity, of course.